Good afternoon, speakers, esteemed colleagues, participants, and committee, and welcome to the second part of UAIS 2021, Day 3. Let me reintroduce myself. My name is Caroline, and I will be your host for today. And we are glad to welcome all of you. But before we start, do allow me to introduce your moderator for this coming session and remind you about the rules and certain functions or feature of this symposium. So throughout this event, should you have any queries, it can be delivered through the Q&A box provided below, and answers will be given during the discussion session facilitated by the moderator. As participants and attendees, you will also welcome to greet the other attendees using the chat box. Please be advised that the entire event will be recorded and broadcasted live through YouTube. And during the symposium, we also provided interpretation features. You can find it in the bar below and look for the globe icon. If you wish to listen to the English version, you may click English or click Japanese to listen for the Indonesian version. And now, without further ado, let me introduce Laura Nevendorf, who will help us in moderating the session about way forward for a better care. So Laura is now doing a doctoral program in public health in Monash University, Australia, funded by the Indonesian Endowment Fund for Education, or LPDP. She is currently the consultant for technical assistance for development of community resources on chemsex and related harm reduction interventions, funded by Asia Catalyst or Global Fund Geneva. So to facilitate this discussion, I would like Laura to take over this discussion. The floor is yours, Laura. Thank you.
Sorry, I didn't realize that I was muted. Thank you, Caroline. So thank you for this opportunity. And thank you everyone for joining us, and welcome to panel session 6 that specifically focused to discuss research on HIV and aging, way forward for a better care. The last panel of the session of the International Symposium on HIV and Healthy Aging. I'm Laura Nevendorf, your moderator for this session. So in this panel, we're going to have 3 amazing speakers. Each will present their work and thoughts for 20 minutes. Participants are allowed to ask questions during their presentation to the designated Q&A box. Our question, comments, and thoughts will be discussed after all speakers concluded their presentation. Before we finish this panel, each speaker will provide a closing statement. So with those explanations, we shall start with the first speaker. So let me introduce you to Dr. Reena Rajasuriar, Associate Professor of the Department of Medicine, University of Malaya, and an Adjunct Research Fellow at the Peter Doherty Institute for Infection and Immunity, Melbourne University, Australia. Dr. Reena coordinates the Translational Research Program in HIV Immunology and Aging at the Center of Excellence for Research in AIDS, or CERiA, in the University of Malaya. Her research focuses on understanding the immunopathogenesis of aging in people living with HIV and other disease model of accelerated aging, namely childhood cancer survival. In this occasion, she will discuss about exploring multidimensional aspect of aging in people living with HIV in Malaysia. Dr. Reena, the floor is yours, please.
Salam siang, and thank you for the invitation to speak at this important symposium on healthy aging with HIV. I was asked to speak on the research that we've been doing on HIV and aging in Malaysia, and I thought it would be useful to share with you some of the processes of how we started in this field, what we've learned so far from the work that we've done, and to reflect on the gaps still need to be addressed in our work in the future. I have no conflicts of interest to declare. This is the outline of my talk. I will first begin by addressing the changing demographics of people with HIV and how this has led us to rethink and redefine how we measure health in this population. Here I would like to share with you the concept of functional aging, which has been central to our approach in understanding the process of aging in all the research that we've been doing so far. I would like to then share with you some pre-implementation studies that we did to help identify gaps in the provision of HIV care in our unit and how these have become our motivation to implement new services in our setting. And finally, I will briefly share with you some work that we did with the community to understand their perspectives of growing old and how this has now become an important component in shaping our future aging research program. The management of HIV has perhaps been one of the greatest success stories in medicine. From once being a death sentence, the advent and wide rollout of antiretroviral therapy has now made HIV infection a manageable chronic disease where people with HIV have life expectancies almost comparable to those without HIV. As life expectancy increases in this population, we see a change in the demographics of people with HIV. In developed countries like in the Netherlands, modeling data indicate that 2 in 3 people with HIV is expected to be more than 50 years by 2025. And modeling data from our own regional Treat Asia network, which is an observational database of 21 different HIV treatment sites in the Asia-Pacific region, shown here on the right. It is estimated that 1 in 3 people with HIV we see in our clinics will be over the age of 50 by 2025. As people with HIV grow older, the burden of multimorbidity has also increased, and this has been mentioned by almost all the speakers in the last 3 days. This study is from the Moderna Metabolic Clinic, and it's almost 10 years now. Though it's quite old, it's one of the first studies to describe this observation. In this study, the authors assessed the frequency of chronic comorbidities in people with HIV and compared that to controls and showed that the proportion of individuals with 2 or more comorbidities in the HIV-infected group was almost comparable to the proportion of uninfected individuals almost 10 years older. And we see similar reports of a high prevalence of chronic comorbidities among people with HIV in the Asia-Pacific region as well, though there are understandably significant variations from country to country. So although antiretroviral therapy has increased life expectancy in people with HIV, this has unfortunately not translated to an increased health span. Now, traditionally, health span has been defined as a period in which an individual spends free of disability, and this is influenced by both their clinical status as well as the socio-economic environment that they reside in. And so, how should we measure health in the setting of HIV? At this point, I would like to introduce to you the concept of functional age. Aging is in fact a measure of an individual's functional capacity, and as we grow older, like it or not, we all start to lose a little bit of function. However, there can be significant variation in an individual's functional capacity at any given age, and we see examples of this in our daily lives. Thus, 2 individuals can have the exact same comorbidities but have very different trajectories of their functional capacity as they grow older. And so functional age is really what we should be aiming to measure in our patients as a surrogate of health rather than the mere absence or presence of clinical comorbidities. We are lucky that our colleagues in the geriatric field have already established many of the tools needed to estimate functional capacity in individuals. These measures used to assess the functional conditions are known as geriatric syndromes or geriatric conditions and have been raised by a number of speakers in the past 2 days. And geriatric conditions are actually a collection of conditions which occur as a result of accumulated deficits in multiple organ systems, and these deficits make an individual vulnerable to situational changes. Now, these conditions encompass an individual's functional ability and include aspects such as nutritional status, cognitive function, physical health, comorbidities, sensory impairment, mental health, as well as the socioeconomic environment that the individual resides in. Collectively, these assessments are known as comprehensive geriatric assessments, and they are usually performed as part of routine geriatric care. It's also been shown that when these conditions are identified early and with appropriate interventions and support, they can be useful in optimizing disability-free survival in individuals. In 2016, we worked with our geriatric colleagues at the University Malaya Medical Center and established the Malaysian HIV and Aging cohort to study the multidimensional aspects of aging in people with HIV. We are currently halfway through the second wave of recruitment for this cohort, but I'd like to share with you our findings from the completed first wave. We recruited patients who were undergoing routine care in our clinic, and controls were from the community who responded to study flyers, as well as friends and family of our HIV participants. Participants had to be 25 years and older, have well-controlled HIV disease on antiretroviral therapy, and a total of 329 people with HIV were recruited and 290 controls. Of this, there were 172 pairs who were matched for age, sex, and ethnicity, and the median age was 42 years. In terms of assessments, we measured a range of geriatric conditions listed here on the left of the graph, and we found that of all of the 10 geriatric conditions that were assessed, all of them were numerically higher in people with HIV compared to uninfected controls. The burden of geriatric conditions, which in this study was calculated as a composite of the number of conditions or deficits that were present in an individual, was also significantly higher in people with HIV compared to controls, even after adjusting for age, sex, ethnicity, education, employment, smoking, and alcohol consumption. We also found a higher proportion of people with HIV even in their 20s and 30s with 2 or more geriatric conditions compared to uninfected controls. And this really highlighted the point that functional deficits can happen in younger individuals, and we should ideally be studying aging from a life course perspective rather than using chronological ages of 45 or 50 years as cutoffs as we conventionally do. When we explored the risk factors associated with the burden of geriatric conditions, we found clinical factors, specifically a low CD4 and CD8 ratio and a history of AIDS-defining illness, as significant. We also found that the majority of risk factors associated with the burden of geriatric conditions were really social, behavioral, and lifestyle in nature. Employment, education level, alcohol consumption, low physical activity, increased abdominal obesity, and social isolation were all associated with increased burden of geriatric conditions. Now, this study highlighted to us that despite having well-controlled HIV disease, there was a high burden of multiple functional, physical, mental, and social deficits in our patients, and even in a relatively young cohort who were engaged in care. Both social, behavioral, and HIV-related factors contributed to an increased burden of functional aging. And there were really important implications both from a clinical and research perspective. In terms of clinical management, it highlighted the need for multidisciplinary team approach in addressing the multimorbidity needs of our patients, and this has been raised by multiple speakers in the past 3 days. In terms of research, it emphasized the need for a more holistic approach in the way we assess aging in our patients, encompassing physical, psychosocial, and functional domains. And this really needs to be done across an individual's life course. After we completed this study, to be very honest, we really didn't know where to begin in terms of addressing the many issues that our patients were facing. We eventually decided to prioritize in the conditions which we felt we had the capacity to manage in our unit, and this was in terms of NCD management and mental health management. And to move forward and to understand where specifically the gaps were in terms of the care of these conditions, we did a pre-implementation study to chart the care cascades for NCD and mental health management. Because all of our patients in the study were screened as part of the study protocol and that their screening results were then reviewed as part of standard clinical care, we had the opportunity to explore areas which needed optimization in the care cascade. And so we did a chart review 18 months after a participant was enrolled in the study to explore how many new cases were picked up as a result of the study screening. And of those who had abnormal screening, how many had received treatment or had been referred to a mental health care provider for the mental health issues. And of those who received treatment, how many had achieved target levels for NCD or at least completed their psychiatric referrals for the mental health issues. In this analysis, we found a significant proportion of new cases of hypertension, diabetes, and dyslipidemia shown here in the light grey portion of the first bar, which were picked up specifically as a result of the screening done in the study, which highlights a gap in routine NCD screening in our practice. Of those diagnosed with these conditions, treatment, whether drug treatment or lifestyle management, were prescribed in 64% of patients with hypertension, 66% of patients with dyslipidemia, and much higher, close to 90% in those with diabetes. However, control for BP, cholesterol, and sugar were very poor across all of the conditions. The NCD cascade was starkly different from the focus of outcomes for HIV care in the same participants over the same period, and this highlighted to us that we really needed to expand our clinical care focus beyond that of viral load and CD4 counts. The gaps were more dire in terms of mental health management, as shown here in the light grey part of the first bar graph, and this was consistent with the fact that we did not do routine screening for mental health issues in our setting. But even when screening was performed and abnormal scores were identified as part of the study protocol, we found that only a small proportion of those with abnormal scores subsequently were referred to psychiatrists, and this really highlighted an urgent need to optimize referral pathways and linkage to care. What was positive in this study was that the majority of those who were referred did in fact follow up with their referrals in the psychiatric unit, and this was contrary to findings in other settings which have found that this was a major step or major gap in continuity of care for mental health for people with HIV. The findings from this study highlighted specific areas which we needed to focus on in our efforts to integrate NCD and mental health management as part of routine HIV care in our clinic. And we are currently in the process of conducting interviews with stakeholders to better understand what might be some of the facilitators and barriers to this integration process before finalizing our strategy. In the last few slides, I would like to briefly touch on the role the community can play in helping design our HIV research program so it is more aligned to their needs. This was a flyer from a community engagement session we did with the Kuala Lumpur AIDS Support Services, where we had multiple small group sessions with members of the community, and both young and old participants were invited, and to hear from them what mattered to them as they grew older, what services were important to them, and how they felt that they could participate more meaningfully in the process of research in this area. And there were many things that we learned from these sessions, which has really helped in shaping our thinking of how we would design our studies and execute our aging studies in our future programs. Unfortunately, due to the time constraints, I won't be able to go through all of them, but I did want to highlight one example of how such an engagement can be helpful. Now, one aspect that we have found challenging in conducting our aging research is in selecting the tools to measure the various health outcomes. One example is health-related quality of life, which is an essential aspect to study in our patients and to measure in our patients. But there are so many validated tools, even those that are specific for people with HIV, and each tool tends to measure a slightly different construct or domain. And so we asked the community to help us identify what aspects were important and help prioritize which would be the most important for them in terms of what measures were important to reflect their well-being as they aged. And from their responses, we mapped out the domains for quality of life and function, which included, among others, community participation, cognitive function, physical independence, and stigma experience, as well as sexual health. And so these domains will help us in identifying a suitable tool moving forward to be included in our research protocols. To end the talk, I wanted to share some of my thoughts on what I think is important to advance the research in the field of HIV and aging in the region. And I've only listed 3 here, but I'm happy to add more and expand on these during the discussion sessions later. As a start, I think we need to work on harmonizing some of the tools we use to measure geriatric conditions. And we also need to establish standardized methodologies to develop normative cutoffs for these assessments, because many of the existing cutoffs that are available have been derived from studies done in the elderly general population, and our patients tend to be younger. And this process will hopefully help build capacity within each country and in the region to be able to conduct studies on aging within their own environment and within their own countries. With harmonized tools, this will help encourage more studies which assess aging from a multidimensional perspective, encompassing physical, social, and mental health, and using a life course approach. This means including individuals younger than 50 years in our studies, as we need a greater understanding of what really influences the negative health transitions as individuals age. And we cannot study this meaningfully if we focus on a population where all of these events have already occurred. In addition to refining our tools and our approach to understanding the process of aging, we also need to simultaneously think about how best to prevent and manage these conditions. And in this respect, we need to increase our focus on implementation research, particularly on models of integrated care for people with HIV. Though there will definitely be context-specific differences in terms of health frameworks within each of our countries, there will be similarities too, and I'm confident that we can leverage on these similarities and learn from one another as we reconfigure our health systems to meet the multimorbidity needs of our patients. And this learning can only happen if we systematically collect and share data on what works and what does not. Thank you very much, and I look forward to an engaging discussion soon.
you, Dr. Reena. What a nice, interesting topic. So, I mean, from your presentation, I think it's the right time. Now is the right time for us to review and redefining the measure of health to assess HIV and aging. And we can also use, and the community can also use, participate, and involve in redefining the measure as well. So it will be more appropriate. It's appropriate for them. And yeah, and also I think one of the interesting thing is to your presentation also make us realize that, come on, the HIV services, we need to move on beyond the traditional view that only focus on case care, but yeah, we need more than that. Thank you so much for your presentation. Now we'll move to our second speaker, Professor Pande Putu Januraga from Udayana University, Indonesia. Professor Pande currently serves as head of Center for Public Health Innovation, a research center that focuses on developing and implementing innovative methods to address public health problems in Indonesia. His research aims to develop public health program and policy for underserved, stigmatized, and marginalized groups in Indonesia, such as female sex workers, men having sex with men, and young people groups. In this panel, he will talk about an implementation research agenda for HIV and elderly population in Indonesia. So, Prof. Pande, now is your time.
Thank you, Laura, for the introduction. I would like to present my presentation in Bahasa. Is that okay? The slide will be in English, of course.
Yeah. We have an interpreter for this. Go ahead.
Okay. So, ya, apakah sudah terlihat di layar?
Yeah, I can see clearly, Prof. Pande.
Oke. Saya mendapat tugas dari teman-teman Atmajaya, ya, PPH Atmajaya, untuk menyampaikan agenda riset, khususnya implementation riset untuk kelompok elderly di Indonesia, ya, khususnya kaitannya dengan isu aging tentu saja. Dan saya ingin mengucapkan terima kasih pada Dr. Reena tadi pada saat kesimpulan beliau menyampaikan pentingnya studi implementasi sebagai salah satu agenda penelitian di masa depan untuk mengatasi isu-isu aging dan HIV ini. Nah, sebenarnya hampir seluruh pembicara ya sudah menyampaikan hal ini. Jadi kita sekarang ini punya ARV yang merubah peta epidemi dan membuat HIV itu dilihat secara berbeda. Jadi kalau generasi 10-20 tahun yang lalu itu melihat HIV sebagai sesuatu yang mengerikan, tadi disampaikan sebagai life sentence death gitu kan, tapi sekarang HIV sudah bisa kita kontrol, kita anggap sebagai chronic problem, dan kita punya pengobatan yang cukup baik dan terus berevolusi ke arah yang lebih baik, sehingga life expectancy itu menjadi meningkat. Dan banyak studi menunjukkan umur harapan hidup bisa sampai lebih dari 70 tahun. Meskipun tadi Dr. Reena menekankan life expectancy beda dengan health expectancy, ya, jadi dua hal yang berbeda. Nah, masalah aging dengan HIV, infeksi HIV ini tentu saja membawa banyak perubahan. Ada perubahan biologi, juga masalah polifarmasi, ya, jadi multifarmasi, kemudian ada masalah isu-isu sosial, dan juga ada masalah individu seperti mental health problem yang kemudian harus dipikirkan. Nah, kalau dalam konteks literatur internasional, kita sudah banyak menemukan atau kita sudah banyak bisa membaca dampak jangka panjang dari hidup dengan HIV, atau termasuk juga pengobatan akibat pengobatan HIV secara jangka panjang. Juga ada banyak studi yang melaporkan tentang perbedaan kohort yang menyangkut kelompok usia, ya. Artinya ketika orang terinfeksi pada usia muda atau terinfeksi pada usia yang lebih tua atau lebih senior, dan kemudian outcome-nya mungkin akan berbeda. kita juga punya banyak literatur atau yang menjelaskan tentang kebutuhan terkait social support, problem-problem yang berkaitan dengan isolasi sosial yang dihadapi oleh lansia ketika terutama lansia yang mengidap HIV. Sehingga kemudian juga akan muncul masalah yang berkaitan dengan caregiving untuk teman-teman yang senior yang terinfeksi HIV. Juga ada problem yang berkaitan dengan stigma, stresor yang lebih tinggi dalam kehidupan. Termasuk juga stereotip yang berkaitan dengan usia lanjut ini ya. Misalnya bahwa usia lanjut itu tidak memerlukan layanan kontrasepsi atau tidak melakukan hubungan seksual sehingga risikonya menjadi lebih rendah. Misalnya ada stereotip seperti itu yang kemudian mempengaruhi bagaimana kita mendeliver program pada teman-teman atau para senior yang usianya lanjut ini. Juga tentu saja ada problem yang berkaitan dengan layanan-layanan pada kelompok usia lansia, masalah perumahan, dan juga income support yang tentu saja memberi dampak pada status atau derajat kesehatan mereka. Nah, kalau kita kemudian lihat angka Indonesia, kita termasuk agak kurang maju dalam studi-studi HIV dan aging ya. Tadi Dr. Reena menyampaikan ada kohort yang dilakukan di Malaysia, dan kalau saya telisik di banyak center di Indonesia, kohort yang secara khusus fokus meneliti aging dan HIV atau usia lanjut dan HIV itu tidak ada ya, hampir tidak ada. Angka prevalensi HIV juga pada usia yang lanjut itu lebih banyak kita punya dalam bentuk estimasi. Survei-survei yang kita lakukan juga masih lebih fokus pada usia produktif dan usia muda. Jadi gambaran kita tentang epidemi pada usia lanjut ini atau lansia ini untuk setting kita memang tidak banyak kita ketahui. Nah, ini adalah angka estimasi yang saya peroleh dari seorang kolega yang kebetulan mengerjakan ini, kolega saya sendiri yang kebetulan mengerjakan itu untuk 2020-2024. Kalau kita lihat bar yang berwarna hijau itu di usia 40 sampai 49 tahun, kita bisa lihat ada kecenderungan itu semakin melebar ya. Jadi pertumbuhan kelompok usia ini akan semakin besar setiap tahunnya. Kalau kita lihat kemudian bar yang berwarna kuning 50 sampai 59 tahun, meskipun porsinya masih kecil, itu akan terus membesar. Demikian juga dengan bar yang berwarna merah yang di atas 60 tahun, meskipun porsinya masih sangat kecil sekarang. Mungkin juga karena kaskade HIV care kita agak buruk ya, artinya putus obatnya cukup tinggi ya, sehingga memang kita mungkin belum punya teman-teman ODA yang usianya cukup lanjut, gitu. Jumlahnya masih terbatas. Jadi, tapi meskipun demikian dengan kepatuhan yang ARV yang terus meningkat, di masa depan kita akan punya proporsi yang warna hijau, warna kuning, dan warna merah ini usia di atas 40 tahun ini akan makin banyak ya. Dan mau tidak mau pemahaman kita akan bagaimana dampak infeksi HIV, pengobatan jangka panjang, kualitas hidup itu menjadi semakin penting sehingga kita bisa mendeliver dan memberikan layanan yang sama baiknya untuk kelompok usia ini. Nah, kalau kemudian saya mencoba melihat dari data kami yang kami punya di Bali ya, saya meminta staf saya untuk mencoba melakukan perhitungan terhadap positivity rate dari 4 klinik yang kami miliki sebagai network klinik HIV di Bali yang bekerjasama dengan pusat studi kami. Itu kita bisa lihat bahwa memang angka positivity rate untuk kelompok usia B dan C ini 45 tahun ke atas, itu 45 sampai 64 tahun itu lumayan ya. Kalau misalnya pada pekerja seks perempuan di sisi sebelah kanan itu ada di angka 4,5 dan 8,3. Kemudian untuk LSL atau laki-laki seks dengan laki-laki di sebelah kiri ada di angka 17,6 dan 12,7. Meskipun secara jumlah atau absolut itu tidak terlalu besar ya, karena memang jumlah tesnya, kalau kita lihat jumlah tesnya ini, jumlah tesnya baik pada pekerja seks perempuan dan LSL itu tidak terlalu besar memang dibandingkan yang jumlah tes di usia produktif di 4 klinik ini. Itu hampir 4.000-an dan 2.000-an untuk pekerja seks perempuan dan laki-laki seks dengan laki-laki. Tapi positivity rate ini yang cukup tinggi pada kelompok usia di atas 45 dan sampai 64 tahun ini menunjukkan bahwa pada usia yang lebih tua, senior atau lansia, risiko itu masih ada dan kita masih menemukan orang dengan angka HIV positif. Sementara concern kita selama ini memang lebih banyak fokusnya adalah pada usia produktif. artinya usia di bawah 45 tahun ya. Saya tidak mengatakan dari 45 tahun tidak produktif, tapi selama ini definisi kita terkait productivity ini memang agak berbeda. Kita lebih seringnya melihat productivity stereotipnya hubungannya dengan sexual activity. Gitu. Nah, kalau kemudian kita review juga kebijakan pemerintah yang berkaitan dengan pengelolaan HIV ya, jadi HIV/AIDS continuum of care kita itu dari HIV negatif sampai fase terminal itu kita hampir punya semuanya gitu. Kita aspek prevention, testing, kemudian pencegahan dengan kondom dan harm reduction. Kita juga sekarang sudah mulai memperkenalkan PrEP sudah beberapa waktu. PMTCT sedang digalakkan terus. Apalagi yang berkaitan dengan diagnosis treatment itu ya itu sudah menjadi fokus prioritas sekarang. Kita juga sudah mendiskusikan tentang home based care, palliative care. Kita hampir punya semua senjata untuk pengelolaan atau pemberian layanan HIV/AIDS-nya. Tetapi kalau kita telisik secara lebih detail, sepertinya tidak ada dokumen yang kita punya, guidelines, modul, panduan, keputusan SK Menteri, peraturan Menteri, peraturan Presiden, atau apapun yang mendiskusikan tentang ini, comprehensive geriatric assessment ini. Kita nggak punya satu framework di Indonesia yang mendiskusikan tentang bagaimana pengelolaan HIV, infeksi HIV pada yang berkaitan dengan aging ini, berkaitan dengan usia lanjut kelompok senior ini. Di comprehensive geriatric assessment ini nggak pernah kita diskusikan dalam bentuk regulasi, kebijakan atau pedoman di level pengelolaan HIV/AIDS Indonesia. Nah, kalau kemudian saya lakukan pencarian secara sistematis ya, ini pencarian sistematis agak ngawur gitu ya. Ketika saya diminta bicara dengan topik ini, saya sudah langsung minta staf saya untuk mencoba melakukan pencarian dengan kata kunci HIV dan kemudian aging atau older di PubMed. Itu hanya kita kerjakan dalam waktu beberapa hari, kemudian juga di Google Scholar dengan bahasa Indonesia, lanjut usia, HIV/AIDS. Hasilnya agak mengejutkan ya, jadi bukan mengejutkan, tapi memang sebenarnya sudah kita bisa duga bahwa tidak ada satupun publikasi yang menggunakan data primer, primary data collection, tidak ada publikasi menggunakan data primer yang dipublikasikan dan terindeks di Google Scholar maupun di PubMed ya. Ada beberapa publikasi yang berhasil kita temukan dengan setting Indonesia, tapi hampir sebagian besar adalah review literatur, atau ada yang scoping review, ada yang essay. Tapi tidak ada yang menggunakan pendekatan data collection secara primer ya. Jadi artinya pengumpulan data langsung. Yang fokusnya memang untuk mempertanyakan atau bertujuan untuk menelusuri kaitan antara aging dan HIV atau mengembangkan intervensi yang berkaitan dengan aging dan HIV. Itu tidak ada. Kalau yang tidak secara sengaja menginkludkan atau memasukkan kelompok usia lanjut itu ada, tetapi bukan itu fokus pertanyaannya. Jadi memang dari sisi riset pun kita hampir tak punya agenda ini gitu. Di framework kebijakan kita sudah tidak punya, di riset pun yang terpublikasi ya. Kalau yang belum terpublikasi saya nggak tahu, karena ini kan kita cari yang dari data yang terpublikasi. Kalau yang terpublikasi pun kita nggak punya, agenda kebijakan nggak punya, agenda riset juga nggak punya. Jadi agak neglected problem ini aging dan HIV ini. Jadi tapi ya kita nggak bisa membiarkan ini terjadi kan. Ini mau nggak mau fakta yang harus kita terima bahwa, dan juga ini kesempatan bahwa populasi dari older adults ini kan dari dewasa yang senior ini kan akan terus bertumbuh ya. Jadi ini adalah opportunity atau kesempatan untuk melakukan riset dengan penekanan pada positif psikologi gitu kan, kesadaran gitu, dan resilience. Dan sangat penting bagi kita untuk mendorong pusat-pusat penelitian untuk mulai melihat topik ini. Nah, pertanyaannya kemudian adalah tipe riset yang seperti apa yang kita butuhkan gitu kan. Nah, kalau kita lihat literatur dalam waktu 10 tahun terakhir, ada banyak sekali literatur internasional yang berkaitan dengan HIV dan aging. Bahkan ada banyak literatur review yang mendiskusikan tentang state of state of knowledge-nya, sudah sejauh mana pengetahuan yang kita miliki tentang HIV dan aging, dan fokus riset berikutnya apa. Jadi roadmap penelitian di banyak negara itu sudah cukup jelas ya. Peneliti-peneliti internasional sudah banyak melakukan itu. Yang kemudian menjadi masalah untuk kita ya, justru sebenarnya negara berkembang adalah kompleksitas HIV dan aging ini sebenarnya membutuhkan riset-riset yang lebih praktis, lebih bermanfaat dari sisi praktis. Jadi menggabungkan antara riset, policy, dan praktis gitu. Ada banyak bukti ilmiah yang kita punya dari literatur internasional, tapi bagaimana mentranslate teori itu ke dalam intervensi secara efektif itu yang masih kita menjadi PR yang belum kita lakukan. Nah, itu sebabnya saya mempropos atau saya mengusulkan bahwa memang lebih baik fokus kita ke depan itu adalah implementation research. Jadi bagaimana mentranslate intervention teori yang kita punya dari berbagai literatur internasional untuk kemudian dipraktekkan dalam dunia nyata, tentu saja dengan melihat kontekstual faktor yang kita miliki di Indonesia dan fasilitator dan barriers yang kita punya di Indonesia. Dan implementation research itu memungkinkan hal itu dilakukan. Nah, tentu saja tidak semua masalah bisa, atau tidak semua pertanyaan penelitian bisa dijawab dengan implementation research ya. Kalau memang fokusnya adalah masih menemukan model atau mencari inovasi layanan, ya tentu saja levelnya masih di kiri ya, di innovation ini tentu saja implementation research tidak bisa dikerjakan. Tapi kemudian dalam seiring berjalannya waktu, ketika kita sudah punya inovasi kemudian sudah diuji cobakan dalam pilot, maka tahapan berikutnya tentu saja adalah mengarah ke penerapan atau pelaksanaan, dan implementation riset itu bisa masuk ke dalamnya. Tapi tentu saja kita nggak perlu menunggu inovasi itu diciptakan di Indonesia gitu ya. Kalau dalam konteks HIV, risetnya banyak sekali dilakukan di negara-negara lain dengan setting yang juga mungkin serupa dengan kita. Thailand misalnya banyak mengerjakan riset berkaitan dengan aging dan HIV. Tadi misalnya contohnya di Malaysia yang sudah dilakukan. Nah, tugas kita adalah kemudian bagaimana secara cepat, karena masalahnya sudah menunggu, jadi artinya teman-teman lanjut usia HIV dengan infeksi HIV sudah menunggu, jadi mau tidak mau kita harus bergerak cepat, dan modalitas riset implementasi ini menjadi penting untuk kemudian mengintegrasikan intervensi teori ke dalam praktek nyata. Nah, kemudian apa topik-topik yang relevan untuk riset implementasi di Indonesia? Kita sedikit meraba-raba untuk ini ya, karena memang risetnya belum banyak, atau ya yang terpublikasi bahkan belum ada gitu. Tapi kalau kita lihat dari literatur internasional ada cukup banyak topik yang kemudian saya rasa fit dengan situasi Indonesia. Jadi dari HIV, pencegahan HIV, kemudian efek dan manajemen dari comorbidity HIV, kemudian mekanisme untuk menua yang sukses, successful aging, kemudian masalah kognitif pada senior, kemudian masalah mental health, penggunaan substans, kemudian masalah network, dan juga perawatan, kemudian juga infrastruktur, dan juga beberapa spesifik isu pada perempuan terutama. Nah, saya akan coba bahas satu-satu. Yang pertama adalah yang berkaitan dengan pencegahan HIV. Ini sepertinya memang ada stereotip ya di Indonesia bahwa HIV itu ancaman untuk usia muda dan produktif. Orang tua tidak punya risiko. Nah, itu sedikit keliru gitu ya. Karena secara kualitatif kita misalnya cukup banyak menemukan pekerja seks perempuan yang usianya di atas 40 tahun, di atas 50 tahun, bahkan saya pernah menemukan yang di atas 60 tahun. Kemudian juga ketika memasuki masa menopause, maka kontrasepsi menjadi tidak begitu penting, dan ini menjadi dilema ketika kontrasepsi tidak begitu penting, kondom juga mungkin dianggap tidak begitu penting, padahal kondom adalah proteksi untuk STI dan HIV. Nah, jadi kalau kita lihat juga di STBP, survei terpadu biologi dan perilaku, atau IBBS kita, pengetahuan komprehensif HIV pada kelompok dewasa juga tidak terlalu baik dibandingkan pada remaja gitu. Jadi memang intervensi kesehatan masyarakat masih diperlukan pada kelompok ini ya. Jadi misalnya bagaimana pertanyaan yang berkaitan dengan program-program edukasi atau pencegahan yang seperti apa yang efektif bisa diberikan pada kelompok lanjut usia, itu menjadi salah satu agenda riset yang penting menurut saya. Kemudian juga yang berkaitan dengan efek dan manajemen dari komorbidity. Komorbid untuk usia lanjut yang dengan infeksi HIV itu cukup banyak ya. Ya bukan hanya karena HIV-nya, tapi juga karena usia lanjutnya. Karena usia lanjut kemudian banyak komorbid yang menyertai gitu kan, yang muncul. Sehingga memang mau tidak mau pertanyaan yang berkaitan dengan bagaimana mengintegrasikan dan bagaimana membuat layanan informasi medis atau penilaian asesmen medis yang sesuai untuk kelompok usia ini. Jadi tidak hanya fokus di HIV, tapi juga di komorbid itu terjadi di layanan. Nah, itu riset yang saya kira sangat penting dalam konteks layanan kesehatan masa depan. Juga yang berkaitan dengan isu-isu polifarmasi dan intervensi apa yang bisa kita kembangkan untuk mengatasi efek dari polifarmasi ini. Juga tentang mekanisme dari benua yang sukses ini, successful aging ini. Bagaimana kita bisa mengembangkan intervensi untuk meningkatkan resiliensi, kemampuan untuk terhindar dari stres, sehingga meningkatkan ketangguhan dari teman-teman di kelompok usia ini dan kemudian bisa lebih sukses dalam menghadapi penuaan atau aging ini. Hal yang lain juga berkaitan dengan cognitive effect dari senior people ini atau orang yang lanjut usia ini dengan HIV. Jadi biasanya sih memang problem yang berkaitan dengan depresi, kecemasan, tadi sudah disebutkan ya, kemudian ada isolasi sosial, bahkan ada kaitannya juga dengan masalah ekonomi, penggunaan obat, itu tentu saja menjadi ancaman bagi kesehatan mental dan gangguan kognitif ya pada usia lanjut, dan bagaimana kita bisa mengembangkan intervensi untuk melindungi mereka dari loss ini, dari kehilangan ini, itu menjadi penting. Hal lain yang berkaitan dengan mental health, jadi angka depresi, kecemasan itu semakin lanjut usia kan semakin tinggi ya. Pada populasi yang non HIV juga seperti itu, apalagi pada populasi yang HIV. Meskipun kita nggak punya angka pastinya untuk Indonesia, tapi paling tidak kita sudah harus mulai mengembangkan pertanyaan-pertanyaan yang kemudian diterjemahkan jadi riset tentang intervensi apa yang efektif untuk mengurangi insiden masalah mental ini pada kelompok usia lanjut yang dengan HIV di Indonesia. Hal yang lain adalah yang berkaitan dengan jejaring, network, dan juga perawatan pada lanjut usia dengan HIV. Jadi kita tahu ya, semakin tua network sosialnya semakin terbatas, limited, bahkan fragile. Kemudian meskipun memang ada asumsi ya, untuk Indonesia hal ini tidak terjadi. Ada asumsi misalnya bahwa orang tua Indonesia lebih terkoneksi dengan keluarga, tapi dengan perubahan sistem ekonomi di Indonesia yang dari pertanian ke arah industri, bergerak ke arah perkotaan, tentu saja problem yang dihadapi negara maju sekarang kita hadapi juga pada orang tua kita. Generasi sandwich kita, anak-anak muda kita kan sekarang koneksinya dengan orang tua akan berbeda. Nah, jadi belum ditambah dengan stigma ya, kalau orang menderita HIV. Nah, jadi kita akan perlu penelitian-penelitian yang mencoba mencari tahu intervensi apa yang bisa kita terapkan, kita bisa implementasikan secara efektif untuk meningkatkan sosialisasi pada kelompok lanjut usia dengan HIV, sehingga memang kualitas hidup mereka menjadi lebih baik. Kemudian juga isu yang berkaitan dengan infrastruktur ya, dan community resource, sumber daya komunitasnya sendiri, dukungan komunitas sendiri terhadap orang lanjut usia dengan HIV, lansia dengan HIV. Kebutuhan pelayanan sosial dan juga pelayanan perawatan pada lansia tentu saja dengan HIV tentu saja akan semakin besar di masa depan, dan infrastruktur kita sepertinya kurang siap untuk menghadapi ini. Kita misalnya saja panti jompo gitu kan, itu yang aware tentang isu lansia dengan HIV itu mungkin sangat sedikit atau bahkan mungkin tidak banyak yang tahu ya konteks itu di Indonesia. Jadi kita akan perlu penelitian implementasi untuk melatih mereka, untuk meningkatkan kapasitas mereka, layanan untuk bisa memberikan layanan yang adekuat pada lansia dengan HIV. Kita juga perlu mengembangkan model-model layanan yang baik layanan klinis maupun layanan psikososial yang menghasilkan outcome yang lebih baik pada lansia dengan HIV. Dan tentu saja juga kita akan harus mengembangkan intervensi untuk mengurangi barrier untuk mengakses layanan. Nah, hal yang lain adalah isu yang spesifik untuk perempuan dan perempuan lanjut usia dan HIV. Untuk konteks kita di Indonesia yang menarik kemudian adalah traditional gender roles ini. Peran gender tradisional ini pada perempuan dengan HIV. Jadi intervensi apa yang kira-kira kita bisa kembangkan untuk mengembangkan strategi coping secara aktif yang bisa membuat teman-teman perempuan lanjut usia dengan HIV ini menghargai hidupnya, memaknai hidupnya secara lebih baik gitu ya. Artinya sehingga masalah mental, masalah kognitif itu bisa kemudian teratasi. Nah, presentasi saya hampir selesai. Yang kemudian menjadi pertanyaan adalah kalau ada begitu banyak topik yang potensial untuk kita garap dalam konteks riset implementasi, tapi kita belum punya apapun, mulainya dari mana? Gitu kan. Saya kira kita mulainya dari apa yang kita punya. Yang pertama dari kohort. Saya kira di banyak pusat penelitian HIV di Indonesia, salah satu senjata yang kita miliki sekarang adalah kohort orang HIV positif maupun HIV negatif, tapi dengan faktor risiko di usia yang cukup muda. Misalnya kami di Bali punya kohort HIV positif, punya kohort HIV negatif di usia yang cukup muda ya, sampai 45 tahun. Tapi dalam waktu 5-10 tahun ke depan, kohort ini akan menjadi lebih senior lagi, lebih umurnya, kelompok umurnya akan bergeser ke arah yang lebih tua. Dan dari sekarang kita harus sudah siapkan, jadi kita harus sudah menyiapkan variabel-variabel yang berkaitan dengan aging, untuk kemudian kita kumpulkan dari sekarang, untuk kemudian dilihat outcome-nya nanti. Hal yang lain yang bisa kita lakukan juga adalah mengintegrasikan masalah HIV ke dalam kohort-kohort yang non-HIV gitu. Misalnya teman-teman di penyakit dalam itu umumnya punya kohort yang berkaitan dengan penyakit penyakit tidak menular, misalnya diabetes mellitus. Nah, apakah memungkinkan kemudian kalau isu-isu HIV itu masuk ke dalam kohort ini? Dan jika ini sudah kita awareness tentang aging HIV ini sudah ada dalam kohort ini, maka pada saatnya nanti pada titiknya nanti kita kemudian bisa mengembangkan intervensi yang sesuai untuk meningkatkan outcome. Dan ini kita bisa sebut sebagai studi implementasi. Jadi kita buat kohortnya siap untuk mengukur atau mengidentifikasi variabel yang berkaitan dengan aging, dan kemudian kita bisa kembangkan intervensi yang sesuai sejalan dengan itu. Yang kedua tentu saja memulai secara baru, gitu, memulai hal yang baru. Dan untuk mulai yang baru tentu saja kita harus dalam konteks implementasi riset kita harus mencari key stakeholders yang memang relevan. Bukan yang sifatnya pasif tapi juga aktif, karena implementasi riset kan membutuhkan kerjasama dengan pemangku kepentingan yang terkait ya. Jadi kita harus menyiapkan network kolaborator yang siap dari berbagai stakeholders kunci, dari berbagai interest group, untuk kemudian mencoba menyediakan effort atau mengupayakan sesuatu untuk melakukan studi implementasi pada lansia dan HIV ya. Terutama mengintegrasikan pendanaan ya untuk riset dan program. Nah, untuk kesimpulan saya hanya ingin menyampaikan bahwa meskipun populasi usia lanjut dan HIV kita sekarang masih belum terlalu besar ya, tetapi ini pasti akan besar di masa depan beriring dengan meningkatnya uptake start treatment kita semakin baik, kemudian kepatuhan juga kita harapkan akan semakin baik ke depan, dan pasti kita akan punya kelompok lanjut usia dengan HIV yang jumlahnya mungkin akan lebih besar, lebih dominan di masa depan. Dan ini membutuhkan penyiapan intervensi sejak sekarang. Dan kita harus sadar betul bahwa Indonesia sejauh ini belum punya framework kebijakan dan juga belum punya peta jalan agenda penelitian yang baik untuk aging dan HIV. Nah, sementara itu evidence dari konteks yang berbeda itu tetap ada ya, tetap bertumbuh. Sehingga saya mengusulkan fokus kita adalah pada studi implementasi atau riset implementasi. Bagaimana mentranslate program teori ke dalam praktek nyata yang terintegrasi dengan program dan layanan. Dan tugas kita lah kemudian secara bersama-sama untuk mengembangkan jejaring kita, berusaha mengumpulkan dana untuk kemudian diarahkan pada riset-riset implementasi yang krusial untuk memberikan pelayanan yang berkeadilan pada kelompok lanjut usia ini. Karena memang kita belum terlalu memperhatikan mereka, dan saya sangat mengucapkan terima kasih kepada PPH Atmajaya ya yang sudah menginisiasi inisiasi topik ini dalam satu diskusi yang dihadiri oleh banyak pembicara. Terus terang ini bukan topik yang familiar juga buat saya. Fokus saya selama ini lebih banyak pada kelompok kerja seks, kelompok LSL, dan itu pun usianya usia muda, usia produktif. Dan ini menjadi tantangan tersendiri bagi kita para peneliti di Indonesia. Tapi ini masalah yang nyata yang akan kita hadapi di masa depan, dan mau tidak mau kita harus menyiapkan. Jadi terima kasih untuk PPH dan semoga sukses untuk acara selanjutnya. Dari saya sekian, Mbak Laura, terima kasih banyak.
Thank you, Dr. Pande. What an interesting topic. So from your presentation, we know that there's so many things to do that needs to be done in Indonesia if we want to respond to HIV and aging, starting from the approach to engaging the older population. And also we need to develop a guideline and also practical research in prevention, treatment, care, and social and well-being levels. So at least, I mean, from your presentation, I learned now that at least we have a helpful direction on what to do next to ensure we have an evidence-based intervention for HIV and elderly population in Indonesia. So like always, I encourage participants to ask questions in the Q&A box. Thank you. And finally, we're going to greet our last speaker. Hello, Professor Peter Reiss. I know it's rather early in the morning in the Netherlands. Thank you for your time and commitment to being here with us. So Professor Reiss is an emeritus professor of medicine at the Amsterdam UMC, University of Amsterdam, Netherlands. He maintains a guest appointment in the Department of Global Health and continues his research through the Amsterdam Institute for Global Health and Development. His research largely focuses on the long-term complication of HIV and HIV treatment, and more particularly in relation to aging. In this session, he will talk about lessons learned and remaining challenges in research into aging with HIV. Please welcome Professor Reiss. The floor is yours now.
Thank you. Can you give me control of my slides?
I think all the presentation is managed by the host, so I don't have any access to your to give you a permit. Sorry about that.
Professor Reiss, do you have any difficulties in sharing your screen, or do you need us to share your presentation?
Yes, I would like you to share my presentation.
Okay. One
and
moment.
then give me control.
Okay. One moment, please. Professor
put
Reiss,
it on
can you now
slideshow?
see the slide?
Have you given me control? Can I have control of the slides myself?
Okay. One moment.
Why don't you stop sharing and I'll try to do it myself?
Okay. Can you now try
I
to share
can't.
the screen?
Yes, I will try and share it. Hold on.
Okay. Thank you.
Do you see anything?
We can see the title of your slide.
Okay, so you can, I think you can see it now, right?
Yes, I think it's better if you have it on full screen.
No, I have it on full screen. Hold on. How about now?
Okay, it's perfect now, Professor.
You see the full screen?
It is now on full screen, yes.
Yes, we do, Professor.
Okay, thank you very much. Sorry for the technology trouble, and nice to be with you this afternoon, I guess, for you. So I'd like to begin by thanking the organizers and Professor Ivanto in particular for the kind invitation to be part of this important and interesting symposium. Okay, so here are my disclosures. So like others have mentioned, whenever I talk about HIV and aging, I always like to begin by stressing that we need to remind ourselves that the fact that we nowadays can address this topic at all is really a testimony of what we've been able to achieve during many years of hard work in developing effective therapies. As a result, people with HIV are increasingly living until older age. And here you see some recent data from my own country, the Netherlands, where at the end of 2019, 52% of people with HIV in care were older than 50, which is up from 11% back in 1996. And modeling work done by Michaela Smit from Imperial College on our data, on our Dutch data, shown on the right, shows that this proportion is expected to increase to over 70% by 2030. As I told you, this has everything to do with the success of ART, and on a global level, we have made amazing progress where it concerns ART scale-up, with almost 26 million people at the end of 2019 having access to ART. And although this means that about 2/3 or 67% of people are covered, it also at the same time means that as many as 12 million people, or 1/3, do not yet have access. And this is, of course, something we should not and cannot accept. Importantly, the figure I just showed you is the global figure. These figures, however, markedly differ by region as well as between and within countries. For example, as shown in the latest UNAIDS WHO data, which were released earlier this year, for the Southeast Asia region as a whole, highlighted by the red circle, the proportion not covered by ART stands at as high as 40%. And clearly, therefore, we have miles to go. Nonetheless, with global ART access having increased so much, the numbers of people living with HIV who are over the age of 50 are increasing worldwide, and this has been mentioned several times. Although the proportion over 50 is higher in high-income countries, as shown by the blue line in the top, than in low and middle-income countries, shown in the various colors below. In terms of absolute numbers of people, millions more who are over 50 are living in low and middle-income countries, as illustrated by the orange line. As you all know, aging unfortunately increases our risk of a wide range of comorbid conditions, which are illustrated schematically on the slide. And naturally, this is also true for people living with HIV as they age. Again, using data from the Netherlands as an example, one can see that approximately 1 in 5 between the age of 60 and 70 at the end of 2019 had 2 or more comorbidities next to their HIV. Modeling projects that by 2030, it will be the exception for a person with HIV in the Netherlands to be living without any comorbidity. And shown here on the right, the trend will be moving in a similar direction in a country like Zimbabwe. And Dr. Reena also showed you data from your own region. What is now over a decade ago, people started to speculate that comorbidities normally associated with aging might occur more frequently and possibly even at younger age in people with HIV, even during use of effective ART. And central to this hypothesis was that ongoing inflammation, in spite of viremia being suppressed by treatment, might be an important contributor, and that this might even result in accelerated and thereby premature aging. In order to address this hypothesis, we were lucky enough to already in 2009 start a prospective cohort study in Amsterdam, the HIV cohort, which a couple of years later also expanded to a collaboration called COBRA, amongst others with colleagues in the UK, who had shortly before established a similar cohort called POPPY. Although I'll be mainly using examples from HIV and COBRA in the rest of my talk, it is important to stress that fortunately many other cohort studies focused on studying HIV and aging have now been established elsewhere in Europe and around the globe. And this slide is by no means meant to be exhaustive, but it shows important examples from each continent. As you know, the demographics of key populations living with HIV markedly differ in settings other than Europe and North America, and it's important to have a global portfolio of studies which take these demographic differences into account. For our own study, when we started the HIV cohort, our main aims were to elucidate if HIV is indeed causing premature aging, and if so, to understand why this is happening, and by doing so, hopefully identify potential ways to intervene. Key features of the cohort were the recruitment of appropriately matched control participants with a similar distribution in demographic characteristics, such as sex and age, behavioral and lifestyle factors, such as the proportion being MSM, smoking, using recreational drugs, exposed to STIs and viral co-infections. And for the HIV positive cohort participants, we focused on people who were virtually all on combination therapy with suppressed viremia, which reflects the contemporary HIV positive population reaching an older age in countries with widespread access to ART. And I think I need to underline the fact with widespread access to ART. And finally, we invested much energy and effort into an identical detailed data collection of both outcomes and potential confounders through standardized procedures and protocols. Concerning the question if comorbidities associated with aging occur more often and at younger age in people living with HIV, Many studies, including our own, as shown on the slide, generally have found a wide range of comorbidities to occur more frequently in people with HIV, including in those with sustained suppressed viremia on ART. An important comment to make, though, is that studies have differed in the size of the differences observed between people with HIV and HIV-negative controls, and the extent to which an increased comorbidity risk was independently associated with HIV status. In many instances, these discrepancies between studies can be explained by the markedly different demographic makeup of the controls, and or the inability to adequately control for important known traditional risk factors for these comorbidities. For example, because they were not known or not measured in the controls. And this, in my view, is really a key issue where our own study has been able to make important contributions. I don't want to spend too much time on discussing the underlying drivers of increased comorbidity risk in people with HIV, including the important role of inflammation, as it could easily justify a separate talk of its own. The key main point I'd like to make, though, using this slide, which references the results of several published analyses of our HIV and COBRA studies, is that the higher comorbidity risk in people with HIV, in case of each specific comorbidity, was multifactorial. Lifestyle-related factors, cardiovascular disease risk factors, body composition, co-infections such as hepatitis C virus infection, immune activation and inflammation, use of particular antiretrovirals or prior use of antiretrovirals, and markers of severe prior HIV disease all potentially contributed, but to a different extent. In other words, the risk factor pattern could not be generalized for each comorbidity. Whereas some risk factors were associated with multiple different comorbidities, others clearly were not. And this shows that when performing such studies, although there may be value in lumping comorbidities together, studying each of them individually is definitely also required. What I've told you so far are all results of cross-sectional studies, but what happens over time in people with HIV with sustained suppression on ART? Does their risk of developing comorbidities accelerate compared to in HIV-negative individuals? The answer, like we've seen for the cross-sectional analyses, seems to be that not every comorbidity behaves the same. For example, when looking at different magnetic resonance imaging measures of brain structure, as well as performing a formal neuropsychological assessment, we found that the differences observed in these measures at time of entry into COBRA 2 years later had remained the same between HIV positive and negative study participants, as illustrated by the lines running parallel and not showing a greater diversion at the 2-year follow-up assessment. In contrast, when we looked at changes in spirometry over a period of 6 years, whilst accounting for smoking, both 1-second forced expiratory volume and forced vital capacity declined significantly faster in HIV-positive participants in the HIV cohort, with a similar trend in the smaller subset of participants who had never smoked. This suggests that, different from what we had observed for the brain, HIV may in some way continue to accelerate lung damage in spite of viremia being suppressed. Now let's turn briefly to the issue whether HIV may affect the actual process of aging. Let me start by showing you our results of measures of immune senescence in the COBRA cohort, as these very nicely illustrate the importance of how the same finding may be interpreted quite differently depending on which control group one uses. When comparing our HIV-positive participants in red to a control group of age-matched blood donors in gray, HIV positives showed significantly more immune senescence, both in the CD4 and CD8 cell compartment than the blood donors. But no differences were observed compared to our matched HIV negative controls in blue. Had we just used blood donors as controls, we would likely have concluded that HIV by itself is associated with immune senescence, whereas using the appropriately matched HIV negative controls, the conclusion is that this isn't the case. In other words, one needs to be aware who one compares. Interestingly, our finding that at least for this biomarker, HIV negative participants also differed from healthy blood donors suggests that factors other than HIV must also be playing a role in driving a process like immune senescence and other aspects of aging. Using a measure of biological age, which was based on a composite of 10 biomarkers which had been identified by an EU-funded project called MarkAge, which was aimed at identifying the best marker of biological age in the general population, we found people with HIV on suppressive ART, again in red, had a greater degree of biological age advancement than our HIV negative controls in the COBRA cohort in blue. But similar to what I showed you for the markers of immune senescence, both groups showed age advancement compared to the healthy blood donors in green. Similarly, using methodology on the basis of magnetic resonance brain imaging to assess premature brain aging, a method which was originally developed by our collaborators in the UK in the context of studying the brains of victims of traumatic brain injury, we found a greater than expected mean predicted age in our HIV positive than HIV negative participants in this cross-sectional analysis from COBRA. As you can see on the left, HIV positive individuals' brain predicted age scores were greater than the training set mean score of 0 by a mean of 2.15 years, while HIV negative individuals' brain predicted age scores were not. And as shown on the right, brain predicted age correlated with chronological age in both groups without evidence of a statistically significant interaction between calendar age and HIV status concerning brain predicted age. Importantly, similar to what I've shown you on an earlier slide for structural brain changes on MRI and neuropsychological assessment, over a 2-year follow-up period, the observed difference in brain predicted age between the two groups remains the same. In other words, there was no evidence of accelerated brain aging in those with HIV, at least not over the limited period of observation, and again, stressing in a population with continuously suppressed viremia on ART. So what are the practical implications of everything I've told you so far? And the previous two speakers have really already expanded on this. Clearly, the clinical management of individuals with HIV as they age needs to reflect the multifactorial nature of comorbidity pathogenesis. Apart from striving for early HIV diagnosis and treatment and the use of least toxic and effective ART to ensure sustained viral suppression, there currently really are no proven adjunctive treatments to directly target residual inflammation or the aging process. It's therefore key to focus on other issues, like stimulating behaviors aimed at a healthy lifestyle, especially where it concerns substance use, exercise, and nutrition. I've left out, but the others have alluded to it, and it's key mental health issues. Interventions to prevent and manage specific comorbidities currently are largely based on general population guidelines, with several useful, also internet-based tools being available, some of which I show on the left side of this slide, which can help guide healthcare professionals with respect to important considerations in the context of HIV. And I'd like to specifically mention the EX guidelines, which have just recently, a couple of weeks ago, been updated, which have a whole chapter on how to deal with comorbidities in people with HIV as they age. So in summarizing the main points of my talk in terms of conclusions and lessons learned, I think we can say, and this has already been alluded to several times, that the number of people with HIV reaching older age will continue to grow globally. Comorbidities associated with aging generally are more prevalent in people with HIV. The degree to which these are independently associated with treated HIV differs, both for specific comorbidities and between studies. Proper interpretation of study results with respect to the contribution from HIV is very much dependent on the comparability of the HIV controls. And this really is the key lesson that we've learned from our own studies. Higher comorbidity risk in people with HIV is clearly multifactorial, but risk factors are not uniform for every comorbidity. Accelerated organ dysfunction in people with HIV with sustained viral suppression on ART may occur, but again, is not uniform across organ systems. Some degree of sustained accentuated aging, no evidence, at least in our studies, of being accelerated in people with HIV once they have sustained viral suppression on ART, which is good news. And finally, the clinical management needs to reflect these insights and needs to be accessible for all. I'd like to end by showing you this slide, which is an annual workshop that we've been running for many, many years, dealing with the long-term comorbidities and the aspects of aging in people with HIV. The next workshop will be held in December online. Too late to submit abstracts, but I would very much encourage those of you in the region who are interested in this area to participate and consider putting abstracts in for next year's workshop and the years after that, because we were really, really keen to get especially junior researchers from other parts of the world, including Asia, to be able to learn and discuss and learn from each other, not only about the basic research, but also very much about how to implement measures in practice. And Dr. Reena, who spoke first, happily has now joined the scientific committee of this workshop, and hopefully will also be able to help in getting you to the workshop. So I'd like to end by thanking, of course, all my colleagues participating in the research, and especially the cohort participants who really provide us with their data, their biological samples, and allow us to do this research. Thank you for your attention.
Thank you, Professor Reiss, for your wonderful presentation. And I personally thought that we should take a note on what you've said earlier in order to significantly move the research of aging among PL-HIV forward. I mean, especially if the risk factor is not uniform from every comorbidity, then we need a lot of things to do to develop a strategy. So thank you. And now we have around 10 minutes for a question and answer. So now we have a question from the participant. The first one is to all panelists. Do you find any specific challenges on recruitment of participants in your research with aging, HIV and aging?
Okay.
Maybe we could go with, yeah, sure, go ahead, Prof.
No, I can start because our study was really, I think, the first cohort study on this topic back in 2009. And we were just lucky. I mean, there was a call for a grant and we decided to write to that and we got the grant. But we were actually very surprised because, of course, we had no clue whether people without HIV would be interested to participate in our studies. So what we did in the Netherlands, back when HIV started, we set up a cohort study on HIV. So this was in the 1980s, comparing people with HIV and people without HIV. And we decided to use that same setting in the municipal health service in the city center of Amsterdam to recruit the people without HIV. But again, these people come to the municipal health service to be checked for STIs. So it was a risk. We chose them because we thought these people would probably be coming from a similar setting as our people with HIV, so they would be comparable. But of course, whether they would like to be assessed, because these assessments take like 1 or 2 hours for everything we do, was a gamble. And much to our surprise, we had a waiting list of people signing up. And the only explanation I have is that it was a way of getting their health status checked. But I can't tell you for sure, but that's our experience.
Okay, thank you. Next, Dr. Reena.
Yeah, I think I echo Peter's observation as well. When we ran our cohort, I think our patients are quite used to participating in studies, but it's the controls that we were quite surprised. But we also had a concurrent ongoing study on aging that was happening. So there was a lot of public awareness and talks that were going on. So that sort of helped increase the baseline awareness within the community to participate in this sort of studies. We unfortunately, I completely agree with Peter with regards to how we select controls are really important in the studies that we do. And we put in a lot of consideration when we started the study. But there's some the challenges that we faced, particularly in settings where MSM, IDU, all the transmission risks are a legal issue. It's criminalized. It's very difficult to recruit controls of similar background characteristics. So that becomes a huge challenge for recruiting controls, particularly in countries where these issues. And at that point, we didn't even have a PrEP clinic going, which we do now, and which is one area where we could recruit controls. So the way we sort of tried to go around it was sort of to enrich our control cohorts with sort of friends of our participants, our HIV participants. Of course, we did a quick HIV point of care before we recruited them, but we had to use those strategies. But in the end, I think so we are actually in our second wave of recruitment. And we have called back our participants, and quite a majority of them have actually agreed to participate. If at all, there might be some delay in making appointments given the COVID situation, and they don't want to come to the hospital setting at this point. But most of them have said they will consider it, and they will give us a call back when things sort of settle. So it's been very encouraging.
Yeah, I can't imagine how difficult it is especially during the COVID situation. Yeah. How about you, Dr. Pande? Do you want to share something?
I don't have a specific cohort for aging population, of course, but we have at the moment 2 cohorts among positive people and also among negative one, but with different objectives. For the negative one, we would like to have incidence. So this is, I think, the first cohort that to try to estimate incidence of HIV among MSM group in Indonesia, while for the positive one, we focus on adherence. So we try to develop intervention for adherence. But it's quite surprising because most of people think that it will be hard to recruit people, particularly negative one in Indonesia. So for our 200 negative cohort people, we recruited only in 1 month. So previously we targeted 6 months for recruitment, 200 people. MSM, but in 1 month we finished them all. So in this social what do you call it, social media era, it's very easy to market research, and when you offer free services, people just will come for that. So and also we use for clinic network, all private clinics. So it's different setting to the government clinic with they're very busy. We use private clinics, so that probably offer different experiences to the participants.
Yeah. So it seems that free healthcare distributed to social media is a good strategy.
Yep.
Okay, our next question is what things needs to be carefully think when you're doing the research with aging people living with HIV? What needs to be considered, I think? What when you're doing a research with aging people living with HIV? Yeah, who's trying to go first?
I'm happy to go first,
okay,
because it really follows up from the previous question. I would say it totally depends on which research question you're asking. When we did our cohort, there was increasing noise based on no data whatsoever that HIV was causing accelerated aging. And people with HIV were getting scared. So that's really the reason why we designed our research the way we did, because we said, if that's the case, we need to find out, but we also need to find out whether it's not the case at all. And if that's the research question, we need to make sure that our HIV negative controls are as comparable as possible to the HIV positives, because otherwise we're not going to be able to answer the question. And I hope I convinced you that we've demonstrated that so far we really have very little or no evidence of accelerated aging when people are well suppressed on treatment. We do find that there is a difference in prevalence of comorbidities and in aging biomarkers, but they don't get worse. The difference doesn't get worse over time. So that tells you that probably that difference to begin with is caused largely, and I think it comes out of Reena's data as well, and many other people's data, probably driven by things that happen during, I would say, untreated HIV infection, severe immune deficiency, exposure to older, more toxic drugs, bad lifestyle, et cetera, et cetera. So I think very key is finding people with HIV, diagnosing them early and putting them on effective treatment early, which of course, as we all know, not just in your region, also in our region, is difficult. We still have 40% of people newly diagnosed every year who are late presenters in the Netherlands. So it's not going to go away, which is why I think we need to focus on the issues that both Reena and Dr. Pande have mentioned very eloquently in their talks. So it depends on the question. The research you design depends totally on the question.
Okay. Next answer from.
Okay, so maybe I'll focus a little bit on what we learned with the study we did on geriatric syndrome. So when the research team, I mean, we are all in work within an ID setting, it was something very new to us, and it was almost alien to think, do we really need to explore this in our patients and really in younger groups? But I think one of the, and something that I often say now, which is a blessing point, was that we started working with the geriatricians very early in designing our study. And so they essentially changed the way we approached the whole study in the first wave. And I always say that if we just stuck working within the HIV team, we would have done a very different study because we had no idea about geriatric syndromes. But it has really opened our eyes in terms of there are actually many other aspects to explore, and that is the reality of aging. In the second wave, we realized that after we finished our first wave and we started disseminating our findings and speaking to the community, we realized that the community had their own ideas of what are important and what they feel should be prioritized. And so that thought process then went into working and refining how we're going to do the second wave of our study. So I think you can get motivations from many different people, but I think it's important to look outside of the HIV field. And particularly, especially, I think this relates to the subsequent management of our patients. We're going to have to work together with neurologists, with psychiatrists, and if you don't work with them now to generate the data, and they don't learn from us that, oh, these are important issues for our patients, they're always going to be quite skeptical about, managing our patients and accepting them as, referrals and so on. And so having them involved from a very early stage will significantly facilitate the subsequent care that we need to engage with these other specialities.
Okay, so Dr. Pande, hold your answer, because we also have like another question specifically for Dr. Reena and Prof. Pande on how cultural background regarding sexuality and aging discussion in Southeast Asia affects gathering data for all the people living with HIV. Please, we only have like limited time, so just a brief answer, please.
I think discussing sexual history is still a problem in our setting. It's culturally a taboo. Patients don't want to talk about it, and doctors don't feel comfortable bringing it up. It's not just in the context of aging. We've done some work to show that our rates of infection in individuals over the age of 50 is increasing, and similar to what has been reported in many other countries. But in the Asia Pacific region, we've actually not had a lot of data. And when we looked at our rates in our unit, we see it increasing. And unfortunately, this group tend to present much later. They tend to have higher mortality risks. And all of this is because they don't get diagnosed early. And often it's because the older generation actually has got a lot of encounter with the healthcare system. They're coming in for comorbidities management, but we're still missing them in terms of, because we do not think that they are at risk of HIV. They are not an at-risk group. We don't explore that at all. And when they eventually diagnose, it's an issue. So I think we need to normalize, somehow we need to work culturally to normalize this conversation, not do HIV testing, which is risk-based, for example, have a system where in your lifetime, everyone gets one test at least. That has been shown to work in the US. So there are different approaches to it, but we need to be more open about talking about sexual health. Yeah.
Okay. Dr. Pande?
Yes, I think I have highlighted this in my presentation that we have to admit that we still have high stigma among people living with HIV in Indonesia, and particularly among older groups, because as Dr. Reena mentioned, that most of us still believe that this group don't have risk to be infected by HIV, because we think that they don't do the things. So I think we have to, at the first thing, we have to improve what we call it. I think this is not the correct word, but kind of cultural awareness of the health provider that the risk is there. I mean, this group still have risk. We can't stereotype them about their sexual activities and others. So we still need to assess the risk. We have to provide the same service or even the better service for this group, because probably they will more close about their behavior, their risk. So yes, this is important topic that we need to build the capacity of health provider for this.
Okay, thank you, all speaker. So it seems now is time to, not really that time, but we only have like limited time. So I will stop with the Q&A. But before we closing this session, it will be great if each speaker can provide a closing remark, maybe starting with Dr. Reena.
Okay. I think I was very, very surprised and very glad. It was very heartwarming to see that there was a 3-day conference on HIV and aging in Asia, which we've never had before. And I think that sort of raises the awareness that we really need to start looking at this. Like it or not, our patients are getting older, the community is getting older, and we are the only ones probably with a vantage point to see the issues that they're facing and what needs to be done. And so we really need to start working in terms of collectively within our own countries and within the region to start moving this agenda forward.
Okay. Prof. Pande?
Yes, I mostly work with very young population, female sex workers and men having sex with men. And in my head, I always think that some people probably work with the senior people, with the older people. So when I look at the literature for this presentation, and I'm really surprised that no one working on this field. So probably some work in this field in Indonesia, but not available data to what do you call it, to provide evidence to the government to do something. So we need to let's gather HIV activists, HIV researchers in Indonesia. Let's gather and provide makes an agenda, make a roadmap to make some insightful research, to make important research, and provide evidence, provide data to the government and to our community.
Thank you. How about you, Professor Peter?
Well, I think what strikes me is that the issues that we talked about are really exactly the same everywhere in the world. So my advice to you in the region would be to really, because I think you're really good at it, to focus on implementation research, like was mentioned many times, and to do it collectively. So to really join forces, to not go the road and think, well, issues in Indonesia are going to be totally different from issues in Malaysia or in Thailand, because I can tell you just from these presentations, they are clearly the same. So I would make a network, start small maybe, but sit around the table, involve people in Thailand, in Malaysia, and Indonesia, those who are interested, and do it collectively. And I think you would probably get farthest that way. And the other thing to mention is this is not easy. You know, the implementation is not easy. Like Reena said, we're ID physicians. We work in an ID clinic. This is not what we usually do. But by talking to our colleagues, by getting them interested, you just need a few of interested people outside of HIV. You can accomplish a lot, and you can start. So that's what I would think.
Thank you. So it seems that the control HIV, it also means that we need to expand our view and work more. Dr. Reena earlier said about I think it's time to have implementation research that focus on integrated healthcare. Prof. Pande also thought, maybe the implementation research can focus on how to deliver the model, the intervention. And Prof. Reiss also reminds us about the challenges if we want to do the research. Nevertheless, it all can be done. It's hard, but it all can be done through a collaborative work. So thank you, everyone. I think it's my time is over now. So thank you again, speaker, for your thoughtful comments and reflection. With that, we can finally end this session. For participants, thank you for your enthusiasm. Now I return the session to the host. Thank you.
Thank you so much.
Thank you.
Reena.
Thank you.
Nice to meet you all.
Nice to meet you all too.
Peter and Professor Pande. Please, if you still have 1 moment to spare, we still have another around 30 minutes, because we will have a closing of this symposium, of the whole symposium. We will shortly share with you on the recommendations, and the recommendations will be done by the head of the scientific committee. Professor Irwanto is already here joining us. So I will need some confirmation before before the recommendation? Are there any PowerPoint to share? Or if not, then maybe in the meantime, for another 2 minutes, we will have an announcement. And before this announcement, thank you so much for all the presenters today. We are really happy to see ranges of topics that were shared with us in the last 3 days. We had social aspects of HIV and aging. We also have, of course, we discuss about the HIV and cognition, and there are some depressing things to consider in terms of the research, and also in terms of as people living with HIV are getting older, we are facing with a lot of comorbidities, and but of course there are some good news that it can be some of the things can be prevented, and also some of the things can be some of the risk can be reduced as well. So before that, I would like to see if Professor Irwanto is already here with us, and Professor Irwanto is going to do a recommendation on the whole symposium. Professor Irwanto,
thank you.
the floor is yours.
Yeah, thank you, everybody. Thank you, distinguished guests, friends, colleagues. I'm very happy to be on the 3rd day with you all, still high-spirited, and I've witnessed also a very interesting discussion for the last speakers. Astri actually has summarized the recommendation. Maybe we need to ask Astri to share the recommendation for me to share with you all. Ada dari Astri atau siapa yang bisa share rekomendasinya?
Do you need me to read the recommendation, or because it's already there? So would you like me to read it, or?
I can read it.
Okay, yeah. The recommendation, the PowerPoint is there already. Is it clear?
I don't have the PowerPoint. Oh, this is okay.
Yeah. Can you see it? Yeah.
I'm sorry.
No problem.
Okay. Basically, we has what I call a culture shock and discussing HIV and AIDS in the aging population. I know that, like myself, it's sad to understand that being old is being invisible. People don't remember you anymore. They don't even recognize you as a normal human being. Some people think that aging population, for example, are asexual, so they won't get any problem with their own sexes. So things like that. But the fact is that they are just like us. They feel lonely. Many of them experience what they call emptiness syndrome. So they need friends. They need also healthy sex. So here we are. We discussed some statistics on aging population who happen to be in HIV/AIDS statistics, and hopefully also from this 3-day symposium, we learn something to move forward. First of all, is the needs and challenges. The number of older people with HIV has been increasing globally and regionally. This situation can can burden the health system to support older people with HIV to achieve healthy aging. First of all, we need to understand that health system delivery, especially in countries like Indonesia, tend to separate services by kind of illness and by age, and sometimes also by gender. But when it comes to HIV and AIDS, plus all the challenges that older people are facing, like comorbidity, for example, the challenges becomes: is it possible for the system to adjust itself so that they're going to be the system is going to be effective in delivering services also for the needs and challenges faced by older people. Next slide, please. Medical condition. Aging with HIV may put the person at risk of age-related non-communicable diseases already, or organ function or dysfunction, chronic diseases, oral and dental problems, of course, diabetes mellitus, arthritis, stroke, cancer, decreased immune system, especially activating the cytomegalovirus infection. Next. Risk of polypharmacy, adverse event, drug interaction, harmful for kidney and liver function. Yeah, because they need to consume a lot of pharmaceutical substances while they are experiencing some kind of pains and other health degrading conditions. Premature cognitive impairment, also chronic inflammation, degenerative process, Alzheimer's disease, for example, HIV-associated neurocognitive disorder. And this challenge, or in this the need for the elderly to understand that eventually one of the classical challenge for being old is forgetfulness. Yeah, education is one of the major factors that contribute to cognitive impairment, and low education is common characteristic of older people living with HIV in low-income countries. I don't know about this, but okay, let it be there. Next. As they are getting older, people with HIV still have personal needs, which may lead to confusion about themselves. A desire to have a pleasurable sexual intimacy may participate in feelings of guilty, selfishness, or even perception of themselves as abnormal. Worried about practicing sex, education program about safe sex practices is limited to young people only. Yeah, this is a problem. This is a big problem. Disclosure will cause embarrassment and afraid of being neglected by a family or partner, family members or partner. Next. Home care. Caring for older people with HIV at home can be challenging for families due to medical, psychological complexity, and of course to cultural and social challenges also. Risk of mental problems, feeling of loneliness, stigma, financial and social status. Older trans women, for example, experience loneliness even more prominently, particularly those neglected by families for an extended period since they were young. Yeah. Transgender population, older trans women with HIV experience loneliness more prominently, particularly those neglected by families. Oh yeah, they do not have people that can be their caregiver, even when they are old and experience multimorbidity. Wow. Many of them have been experiencing stigma, persecution, bullying, and discrimination due to their gender identity. At a later age, they struggle financially due to limited job opportunities and difficulties in accessing social security. Yeah, and also the current social security scheme is biased also, yeah. I mean, the more and more stigma in this actually very beautiful program. Next. Lessons learned from current practices. Personal experiences of living with HIV for 15 to 20 years of living with HIV. Keep adhering to antiviral treatment. Supporting others who have just been diagnosed with HIV or struggle with that treatment has helped them keep fit and maintain their own healing. So being there for other person actually also help them to stay to adhere with antiretroviral treatment. Next. Practicing an active healthy lifestyle, maintaining healthy lifestyle, balancing diet, moderate drinking, and regular physical activities, doing fun activities or hobbies. Also important to emphasize that all the people living with HIV prefer to be treated as the same as any other elderly. Treating them in a special way may also make them feel that they are less dignified. Okay. Next. Other people with HIV who is a divorcee and widow, manage poverty, mental health, and physical illness, manage intersectional stigma associated with marital or relationship status, enacted stigma associated with HIV status, associated with the physical illness and moral stigma. Burden in social security, basic needs, lack of permanent home, and lack of access to healthcare and insurance. Next. Lessons learned from current practice. The HIV programs have succeeded to improve HIV test and treatment coverage. The HIV services can be embedded in private healthcare and community. By doing that, the number of new infection, severe HIV and AIDS cases is decreasing. Health services dedicated to addressing older people's needs are increasing. Many medical facilities apply elderly friendly environment. Such initiatives have supported older people to live with chronic diseases, achieve healthy aging, and improve their quality of life. However, there is still a need for integrated health services that can address the needs of older people living with HIV. Yeah, next, recommendation. Healthy aging is essential to increase the quality of life among older people with HIV. A multidisciplinary team, geriatricians, infectious diseases specialists, internists, cardiologists, neurologists, psychiatrists, nutritionists, physiotherapists, psychologists, pain specialists, urologists, and general population, including a social worker, patient client-centered approach, a coordinator to. Yeah, and because of the nature of the multidisciplinary team, we need some kind of organization of coordination to ensure that the care can be delivered smoothly and effectively. Strengthening the whole health system, especially the referral system. Next. Considering some older people with HIV may prefer to be treated at home, enhancing the caregiving skill of family members is essential. The complexity of medical and psychological problems of older people living with HIV requires an understanding of the problems and, in particular, caregiving skills to handle them. By doing this, it will also help reduce the need for formal services. In addition, healthcare providers should strengthen collaborations with civil society organizations, including supporting their initiatives and reaching out, providing caregiving, and establishing a support group for older people living with HIV. Next. Since disclosure can still be an issue for older people with HIV, it is fundamental to help them understand the benefit of opening their status to family and relatives. Disclosure is not only to prevent transmission, but to build a support system for the person. Existing programs on both HIV and older people should be closely monitored and evaluated. If possible, they can be escalated to address the needs and challenges of older people living with HIV more comprehensively. Next. Experiences of stigma and discrimination have a cumulative impact on health and well-being over the life course. To eliminate the effects of intersecting stigma and discrimination among older people living with HIV, we need to guarantee stigma-free and safe health services for them by providing training, monitoring the healthcare worker, and involvement of PL-HIV in training and monitoring. We also need to guarantee comprehensive health services for PLWH, increasing support to encounter accumulated impacts of stigma and discrimination by providing a program to promote financial security, create social belonging, and improve long-term care access. Legal reform and enforcement of laws also needed to create a safe and secure right for older people living with HIV. The imposition of social and cultural norms on healthy aging needs recognition of the impact of structural and social inequalities that impede healthy living in later life. Developing guidelines and policies for establishing comprehensive programs and services from the early stage of continuum of care to terminal phase for older people living with HIV is recommended. Such guidelines and policies should consider and be adjusted to the local wisdom and culture, and involve multidisciplinary stakeholders, and importantly, the older people living with HIV and their caregiver in the development process. More studies are needed to obtain insight and understanding on older people living with HIV. I think we are in the beginning for more fruitful studies in this field, and especially study older people living with HIV from their own perspective to a broader and micro perspectives. In particular, assessing multidimensional aspect of aging from a life course perspective, HIV prevention strategies, the different needs, challenges, coping strategies, and healthy risks based on gender, sexual orientation, and mode of transmission, the effect of ART and a person's physical, psychological, sexual, and social life, implementation study in the cohort. I would also see the need to study the culture of care in state organizations as well as in community organizations for the elderly with HIV. Next. Enhancing research on HIV and aging as a point needs to be considered. Develop a national research agenda on HIV and aging. Harmonization of tools and normative cutoffs for geriatric assessment. Proper interpretation of study results with respect to the contribution from HIV is very much dependent on the compatibility of the HIV negative controls. Expand the network, stakeholders, and encourage integrating funding into research and program activities. Thank you, everybody, for a very, very fruitful 3 days. I hope you enjoyed your participation And I hope this is not the first time that we collaborate. We need to continue our collaboration and the high spirit, and of course, to make older people not invisible anymore. I think it is our task, especially for many of us who are also getting older and be part of the population that we are discussing right now. Thank you so much, everybody, especially Dr. Astri, Caroline, FP. The organizing committee has been very, very wonderful, hardworking, and also to our international friends and colleagues who has been very, very supportive. The Ministry of Health, including Dr. Nadia, who have been wonderful ally for HIV/AIDS prevention, and also for our research. So thank you so much. I hope we all get the benefits of the 3 days that we engage in discussions. Thank you.
Thank you so much, Professor Irwanto, for the wonderful rapporteur. And now I would like to call on Ibu Evi Sukmaningrum, Ibu Evi Sukmaningrum as Director of University Center of Excellence, AIDS Research Center of Atmajaya University, Catholic University, to officially close this symposium. Ibu Evi, will you be able to join us? Okay, thank you so much. Now we are reaching this complicated goodbye, which we started with a simple hello. Okay, Ibu Evi, the floor is yours.
Yeah, good morning, good afternoon, and good evening to all symposium participants, distinguished guests, and also our colleagues. On behalf of our center, I think this is the time has come for me and for us to close this symposium that has been held from November 24 to 26. And then we are all have listened, learned, enjoyed, and gained awareness and enlightenment from the speakers, and also the rich discussion that have been taken place related to HIV and aging issues. And then it seems that if I could give a reminders that we have achieved some of the objectives, perhaps not all, for the symposium. And we all get to identify and discuss the health challenges that faced by people living with HIV at a later age. And during the sessions, we also did exchange knowledge and experiences on research and programs related to people with HIV at a later age from different countries. And we hope that we could establish collaboration between affected communities, scholars, and professionals in developing activities and programs to support people to achieve healthy aging. And we just learn as well and wrap up the recommendation coming from all sessions that has just delivered by Professor Irwanto as a very important take-home message for us. And yeah, we will send the complete document recommendation to you all. And I think we need to start to think and do action from now to the years ahead, because we will have growing number of people over age 50. And as recommendation, it requires research, policy, and practice to develop a more comprehensive understanding of the health consequences, not only physical, but also psychological, socioeconomic, and so many more that related with people living with HIV in older age. And it is our collective responsibility as academic society, as part of community and civil society, as professionals, as people living with HIV, caregivers, policymakers, to collaboratively join in providing better care for people living with HIV and support them to achieve healthy aging. And now I will quote this statement coming from Dr. Linda Bennett just now, because this is a very important message, I guess, to stress that healthy aging is not just about a specific age group, but about the process of aging. However, people who have more resources to draw on will to draw on will age more slowly than those who experience disadvantage, such as also stigma and discrimination. So people who are HIV positive will not just age more quickly due to their viral status, but also because of structural disadvantages. So yeah, this is our responsibility again, and healthy aging is essential to increase the quality of life among older people with HIV. And before closing this series of events, I would like to thank all the expert speakers and the moderators who have facilitated these sessions. I also thank to the organizing committee team, Dr. Astri, who lead all the process, and the supporting and great team who worked very, very hard for this event happen. I will mention Edwin, Amalia, Lydia, Lengo, Caroline, Haidar, Cynthia, Nina, and I also will thank to the scientific committee from all these 4 continents, and Prof. Irawanto as chair of the scientific committee, Dr. Linda Bennett, Dr. Judith Levy, Dr. Eko Prasetyanto, Dr. Juliana, Dr. Yuda, Dr. Gambit, Ibu Kritayawan Bontu, Dr. Ralph Hemmers, Mrs. Merinda, Mr. Daniel Margueri, Dr. Siti Nadia, and Prof. Zubairi in providing advice and support from the preparation process until the end of the symposium. And then last but not the least, thank you to all conference participants who have participated in this 3-day series of events. I wish you all stay healthy, keep mindful, and stay happy. We will see you again on the next and other events. And on behalf of our center, we also apologize for the technical aspect that might happen during the event. And thank you very much.